cost. That's what this law is supposed to do. What does it really do, in my opinion? Well, first of all, the cost of health care is going to continue to increase. I don't care what you do, okay? And furthermore, it's increasing in every single country in the world. I've traveled the entire world. I've given lectures in the world. I've done business opportunities in the world. It is increasing in the developing world. It is increasing in Europe. It's increasing in the developed world. Now, we're starting at a different baseline. You know, we're at about $9,000 per family, okay? Double Europe, 3 times Asia. But they're increasing too. And they're having the same problem. I mean, no one's sitting around saying, oh, wow, we're not spending a lot of money on healthcare. Ain't happening. And that's because we're getting older. We're living longer. There's more technology for us to be used when we get sick. It's going to cost money. Economics, it's a superior good, and it's scarce. The older you get, the richer you get, the more you want it. It's a very special economic factor. Now, here's the Medicare. No matter what you do, in 2011, 37% of the money, if you look at Medicaid and Medicare, it's about 59% comes from the government, but still a big chunk from the private sector. In 2020, because of the aging population and this law, it's going to be more, okay? And the cost, here it is. As a hospital owner, I'm not going to tell you anything nobody else would say. We all survive on what Mr. Terrell provides us. If it wasn't for private payers, we would be under the roof. We wouldn't be able to open our doors. Look at this. The margins have gone down to negative 10% with Medicare. At times, negative 15%. I lose money on every single government patient that comes into my hospital. I've made calculations. I can make $5 million more by closing my hospital to government patients. And I don't, and I'm taken care of. But it doesn't work. It doesn't cash flow because of the payment. Now, yeah, you can increase reimbursement. Where are you going to get the money from? Where in the budget are you going to get the money from? Big issue. Look at the margins here. Everything. We used to make money in outpatient, no mas. Inpatient down, outpatient down, overall Medicare, everything is negative. This is coming out of the Kaiser Health Foundation. And despite the fact that people are paying more and more for health care through additional premiums and things of that nature, there still isn't the behavior, the consumer behavior that would try and put a strangle on this tremendous increase in healthcare costs. Now, this comes from the Kaiser Foundation. This is total aggregate healthcare costs with and without the ACA, okay? With reform, or what they call the ACA is red, without is blue. Identical. In fact, it's a little bit higher. This is out of the Kaiser Foundation. An independent, total, more of a public policy group than anybody else. It does not slow down the aggregate healthcare costs. Why? All microeconomics. All microeconomics. Everything pertains to a Marshallian supply and demand curve. If something costs a lot, you're going to use less of it. If something costs less, you're going to demand more of it. The problem is patients never see the cost. Because of Mr. Terrell here and the government, they never see the cost. They never shop for health care. They never try to do behaviors where they, improve their chance. Hey, if I get sick, I'm going to lose money. I'm not going to be able to take that trip. They don't do that. They do it with cars. They do it with hotels. They do it with restaurants. They even do it with schools, but they don't do it with healthcare. And what happens is that healthcare is a scarce resource. It's a superior economic good. You're going to have an unlimited demand unless you have some sort of control. Now, how do you get control? There's direct rationing. That's Canada. Canada says, look, this year we're going to spend $100 billion on healthcare. And when we've spent it, guess what? We just closed the floor. Emergencies get shipped to the United States. 85% of their population lives within 200 miles of the United States. Then there's indirect rationing. That's almost what this country is doing. Let's pay you so little, that you won't produce anything. That leads to lines. That's why in those countries, doctors, they're neurologists, they work from about 10 in the morning to 3 in the afternoon. Why don't they work more? Do you know that in the province of Quebec, if a doctor makes more than $350,000, he has to pay the money back to Canada? His salary is capped at $350,000. It's the only career in Canada where the government says that you cannot make more money. Now, when that started, what did they do? They worked for 3 months, night and day, and then they went to Miami, okay? And they worked there. And do you know what they did? They said, okay, it's divided in quarters. That's Canada, okay? And that's indirect rationing. And now you've got the consumer-based systems. And let me tell you something. We're way behind in this country. Asia is where it's happening. In these countries, particularly India, you have a private system where the consumer pays, is savvy, understands the market, and makes rational decisions. And I'm going to leave you with one topic. A patient has a heart attack in India. I was in Hyderabad. The patient goes. He's presented a menu of options. This is the cost if you get bypass surgery. This is the cost if you get a stent. Now, you pay this if it's a stent that's not approved by anybody. You pay this if it's a stent that's approved by the Indian Medical Association. And this is what you pay if it's an FDA-approved stent. And do you know what? They pick open heart surgery every single time. It's cheaper. It's cheaper. Now, look what happens in heart surgery. 99% of heart surgery in India is closed, meaning they don't put the patient on heart-lung bypass. The Indian surgeon has learned to operate on a beating heart. And they do incredibly well. And why? Because the total cost for a heart bypass in India, in Hyderabad, is $4,500 US. Medicare, where we barely make money, pays us $50,000 US. 10 times in India. I pay $1,500 per bypass just for the machine in my hospital. And the Indian said, look, we can't do this. There's no money unless we learn how to do it closed. We'd have to close the hospital. So what happens? The doctor learns how to do it closed. I've been pleading, praying with my open heart surgeons to learn how to do closed heart surgery. Not done. The market works. The market works. People are paying. They came up with innovation. It's no different than an iPhone. I mean, think about this if this was a medical device. You know what this would cost? $100,000. Easily. Apple would make a bigger spread. But wait a minute, how many of us can afford a $100,000 phone? We can't. So all of the technological forces worked to basically make this cheap. Final note here, when all government, in little as in great things, shall be drawn to Washington as the center of all power, it will render powerless the checks provided of one government on another and will become as venal and oppressive as the government from which we separated. This wasn't a Tea Party, or this was Thomas Jefferson. What we've done is we've given the individual patient-physician relationship to Washington, D.C. Don't do it. Don't do it. No matter how good they want to be, no matter what their intentions are, they will not be able to make decisions as well as you can make yourself. And thank you for your attention.